Hello everyone. So, today I am here to discuss a new topic which is on National Health Intervention Program for Mother and Child. In this program, we are going to discuss about the quality care which is provided to mother as well as to the child. So, let us start. So, our Government of India adopted the reproductive maternal, newborn, child and adolescent health, which is also known as RMNCH plus A. R here is the reproductive, M is maternal, N is newborn, C is the child, health plus adolescent age we have added. So, the care which is provided to all of these phases we are putting under RMNCH. Yes, this framework is given in 2013. Yes, it essentially aims, and our aim for this program is to prevent the major causes of mortality and also the morbidity. Okay. So, the reasons which are causing the disease in these of the ages and how we can prevent this thing. Yes. So, our main goal is to reduce the mortality, means the death rate, and the disease, means the morbidity among women and child. Okay. Now, this framework also helps to understand the delays in accessing. Okay. When we are monitoring the data, means how why the women and children, they are not getting the proper facility, and this is causing the morbidity or mortality in these age groups. Yes. Then by this, all of this, we get to understand where is the delay. Yes, in accessing and utilizing the healthcare services, either it is available at primary healthcare center or secondary or tertiary. Okay. So, by all of this, we will get to know where is the problem and how to correct it. Now, see, based on the framework which is given in 2013 under this reproductive, maternal, newborn, child health care plus adolescent, comprehensive care is provided to children and women. Yes, through 5 pillars of the thematic areas. Now, what are these 5 pillars? So, reproductive, maternal means the mothers, neonates, okay, means newborns up to the 1 month of the age. Yes, then children's, yes, and adolescent up to the 19 years of age. Yes. Now, the program and strategies developed by various divisions are guided by central tenets of equity. Okay. We are making any plan, it could be for elder, it could be for mother, it could be for the child. So, what we want to achieve from these program, okay, is only possible by some points such as equity. If it is given to all, okay, if it is given to women or children in equal amount, that is called the equity. Okay. So, equal services should be provided to all. Universal care, okay, it should be standardized. Yes, everyone should be entitled for it, entitlement and accountability. Okay, everything should be noted, each and every data should be noted. Yes, that means it should be accountable to provide the continuance of the care. Okay, and ensuring equal focus on various life stages. What do you mean by various life stages here? Of course, the points which we have done before, like reproductive phase. Okay, what are the problems which are associated in reproductive age? Okay, there are some STI, sexually transmitted diseases, reproductive transmitted infections. Yes, then maternal, okay, the mother age. Yes, the mother phase. So, the problem associated with mothers in the pregnancy, they are accountable in it. Okay, neonates, children, child phase, adolescent phase. So, these phases are covered in this National Health Intervention Program for mother and child. Now, see, one of the scheme we have in recent time, means it is in 2019, one scheme is launched which is known as SUMIN. Okay. Ministry of Health and Family Welfare, Government of India has launched a new initiative, and this scheme is known as Surakshit Matritva Ashvashan. Yes. Now, what is the goal of this scheme? Yes. It has an aim to provide assured. Okay. So, what are the services provided? It should be assured, dignified, respectful and quality health care, yes, at no cost, and zero tolerance for denial of these services. Yes. If there is a zero tolerance for denial of services, of course, we can improve our health care, yes, for the women and child, and thus we can prevent the mortality and morbidity in these phases. Yes. For every women and newborn who are visiting to the public health facility, means the government facility, yes, in order to end all the preventable maternal and newborn deaths. Yes. Now, there are many reasons why there are deaths or disease seen in maternal and newborn. Yes, they are more susceptible. Yes, and there are many reasons, like there could be hemorrhage, okay, at the time of the delivery. Yes, there could be sepsis, this infection could also be there. Yes, sepsis, there could be tetanus infection also, we have seen. Yes, sometimes there is a comorbidity, hypertension, diabetes, like these diseases. So, these are some of the reasons why we have seen the morbidity or mortality in maternal and as well as newborns. For the newborns, we can say there are reasons such as sepsis, okay, infections are there in this phase. So, we can prevent the deaths only when we can improve our programs. We can improve the programs, the points which are under this. If we are implementing it in a better way, of course, will prevent these deaths as well as disease. Yes. Morbidities and provide a positive birthing experience. Okay. So, our main goal of the program or the scheme which is launched in 2019, Surakshit Matritva Ashvashan, is to provide quality care, assured care, dignified care at no cost and zero tolerance for denial of these services. I hope this is clear to all of you. Now, we will see the expected outcome of this new initiative. Yes. So, we want to achieve a zero preventable. What the reasons we can prevent, that we want to make it zero. Yes, and newborn deaths and high quality of maternity care delivered with dignified and respectful manner. Yes. Following this strategy, the Maternal Health Division strives to provide quality services to pregnant women and their newborns through various interventions. Okay, means various choices, various options. So, and programs, building capacity of health personnel. Yes, if we want to give the facility to all of the women's, okay, in the reproductive stage or in the pregnancy or to the child care or to the children's or to the newborns. So, for this we have to maintain or we have to build the capacity of the health professionals as well. Yes, we need the skilled workers, we need the staff, we need the skilled staffs. Yes. So, for this it is very necessary to build capacity of health professionals and routine health system strengthening. There should be a monitoring system, there should be a tracking system by which we get to know, yes, we are doing good by implementing the programs. Yes. Now, see, there is one ratio we are calculating, and on that basis we are deciding, yes, the programs are going good or not. So, there is a one ratio which is called as a MMR. Yes, maternal mortality ratio. Now, what do you mean by this MMR? Maternal mortality ratio means the number of maternal deaths per 1 lakh live births Yes means how many babies are born, live births at particular period of time. Yes. So, this is known as MMR, maternal mortality ratio. Yes. So, India's maternal mortality ratio at present, the data we have, it is 130. Yes. And this is data of SRS, Sample Registration Survey 2014 to 16. Okay. If we see our previous data, means the survey which is done in 2011 to 2013, at that time our MMR ratio is 167. So, by this we can compare, we have improved. Yes, our maternal mortality ratio declines from 167 to 130. Yes. And how it happens? Of course, whatever the programs we have launched, the institutional deliveries which we are going on, okay, and we have controlling on the infections which are very common in mothers and children. That's how we have prevented the maternal mortality ratio. Yes. So, see, this is maternal mortality ratio and all India status, source of the data here from the sample registration survey. Yes. So, in 2004 to 2006, it was 254, it was too high. Yes. Now, if you will see in 2007 to 2009, it is declining from 254 to 212. Then we can see in 2010 to 12, it is 178. Okay. In 2011 to 13, it is 167. And now the data which we have is we are on 130. Okay. But we want to achieve it to 100. This is under our National Health Mission NHM goal, which is provided in 2017. Yes. So, we have a goal to achieve a MMR at least up to 100. Okay, by launching the programs, by launching the schemes up to the ground level. It is very needed. Yes. Now, see what are the indicators, maternal health indicators by which we will identify the maternal health, means the mother's health. Okay. So, how will identify it? First is, we are seeing the mothers, means who are in a pregnancy stage. Yes. So, mothers who had taken antenatal checkup. Yes. See means antenatal checkup means the checkup which the mothers are taking at the time of the pregnancy in the first trimester, means in the 3 months, initial 3 months. Yes. So, there are two surveys. Yes, National Framework Health Survey 3rd and National Framework Health Survey 4th. The recent data we have for the National Framework Health Survey 4th, nearly to the 2016. The ratios, the values are written here. So, the mothers who had taken the checkup at the time of pregnancy in initial 3 months, we have seen the ratio, the percentage got increased. Yes, it increased from 43.9 to 58.6. If we will see the other indicator which is showing the maternal health. So, mothers who had at least 4 antenatal care visits within the time of the pregnancy, okay, in the 9 months, there is a standardized visits. Okay. So, these visits are at least 4 visits. So, those mothers who had taken at least 4 visits during those 9 months, the values we are seeing here in the survey which we did in the India is improved. We have improved from 37 to 51.2%. But yes, there is a scope to increase more, and we are working in this way. Okay. Another indicator we are seeing, mothers who had full antenatal care. Yes, full antenatal care includes many of the things. Yes, the visits as well as all of the tests or the therapies they are getting at this particular period. So, with this include full antenatal care. Now, if we see the percentage, so we have also improved in this third indicator. It's from 11.6 to 21%. Yes. The fourth indicator we will see here, mothers who received postnatal care. Now, what do you mean by postnatal care? Means the care which is provided after the delivery of the baby. Yes. So, that means the postnatal care. Now, this postnatal care of course will be delivered by by the doctor or by the nurse. There are some LHV, lady health visitors, then auxiliary nurse midwives, ANMs, midwives or other health personnel within 2 days of the delivery, which I told you. Yes. So, see the percentage we have improved in this one also from 34.6 to 62.4. Now, fifth indicator is the institutional births. Okay. And why we are focusing on the institutional births? Because there are many reasons of the deaths in mothers, and one of the reason from all of these is the unskilled delivery. Yes, where the unskilled professionals they are doing the delivery of the mothers, and thus the infection are more prone. Yes. So, institutional birth should be 100%. Yes, this is the ideal value, but where we are see from 38.7% to 78.9% we are reached here, and we want to achieve it up to 100%. Yes. So, these are some of the indicators through which will identify the maternal health. Yes. Now, see what are the quality service provisions. Okay. So, the services which are provided to mother as well as to the child. Quality antenatal care, the care which is provided at the time of the pregnancy. These are quality and comprehensive ANC, antenatal care, incorporates minimum of at least 4 ANC. I told you the same thing. There is a standardized value, and these value we have taken as 4, at least 4 antenatal care visits should be there, which includes early registration, first antenatal care within the first trimester, within 3 months. Okay. Early detection of high risk pregnancy. If we identify there is a high risk pregnancy, of course we can manage it better. Yes. And we can prevent the mortality in mothers. That is why we are saying the at least 4 antenatal visits are required. Follow up is required, and management are important component of antenatal care. So, this is under the quality antenatal care. Now, see what are the other services which are provided to the mother. The ANC package means the antenatal care package. When the mother will visit the clinic, what package they will get? One is the physical and abdominal examination by the ultrasound. Yes, HB estimation, hemoglobin estimation. This is very required because the high risk pregnancy also includes the anemic situation. So, we want to estimate the HB so that we can treat the pregnant women by prescribing the iron and folic acid. Yes. Or if it is required, then injections can be given. Screening of gestational diabetes. In the very initial I told you why there is a death in mothers. So, one of the reason is comorbidity. Yes, diabetic mother, diabetic pregnant women, or hypertensive pregnant women. So, these should be screened. If it is screened at a initial point, we can manage it better. Thyroid disorders, HIV and syphilis, they are transferable to baby also. Okay. So, we need to screen this HIV and syphilis. Urine investigation is required, and there is injection of tetanus, and there is another injection we made, tetanus with diphtheria. Yes, TD. So, these injections are required because I told you sepsis is also one of the reason for the maternal mortality. Yes. So, tetanus injection and tetanus diphtheria immunization, distribution of IFA, iron folic acid tablets when the pregnant women is anemic. Calcium, yes, 6 months during antenatal period within the pregnancy time and 6 months during postnatal after the delivery. And counseling for nutrition is required to the mother as well as to the newborn. Now see, essential obstetric care during delivery. So, Government of India provide the free institutional delivery, okay, with no cost delivery at government hospitals. So, free institutional delivery are required because the skilled workers will skilled personal staff will perform the delivery. So, that the chances of the infection, the chances of the mortality will be less. Yes, because they are trained to how to deliver, how to reduce the infection. Yes, at its network of health facilities including, and where these facilities are available at the public health centers. So, if we will see the hierarchy, so they are available at everywhere from the sub center to the tertiary healthcare centers. Yes, sub centers, then we will see the primary healthcare centers, secondary healthcare centers, tertiary healthcare centers. Okay. The same is written, the sub centers, primary health centers, community health centers, sub district hospitals, district hospitals, etc., to reduce the maternal and neonatal morbidity. So, that is why we are focusing so much on the institutional delivery. Yes, delivery by the skilled health personnel. In order to provide essential obstetric care services, the Government of India is operationalizing the 24/7 primary health center services and providing training to staff nurses, lady health visitors, auxiliary nurse midwiferys under the skilled attendant at birth. Yes. Now see postnatal care for mother and newborn. So, postnatal care means after the delivery. Yes, so care is required at the time of pregnancy period as well as after the delivery. Now, ensuring postnatal care within 24 hours of the delivery, yes, within a 1 day of the delivery, and subsequent home visits are required. When these visits are required, see, we have put some values like 3rd day, then 7th day, 14th day and 42nd day is the important components for identification and management of the emergency. So, most of the infections we have seen up to the 1.5 months after the delivery. Yes, that is why we have taken these values, the 3rd, 7th, 14th and 42nd day. So, at these days home visits are required, and who will do these home visits? Of course, the health professionals like lady health visitors, staff nurses, they will go, they will see, they will do the follow up, and they will see the what is the condition of the pregnant women right now. Yes, and if it is required, then it should be managed. So, management of the emergencies occurring during postnatal period. So, that is we can remove the mortality and morbidity. The A&M, auxiliary nursing midwiferys or lady health visitors or staff nurses are being oriented and trained for this work, for the home visits and to identify or to tackle the emergencies which are associated with the postnatal period. Now, see the provisions of emergency obstetric and neonatal care at FRUs. What is FRUs here? First referral unit. Yes, and first referral unit could be sub-center, could be district health center, could be primary health care centers. Yes. So, see provision of emergency obstetric and neonatal care at first referral unit is done by operationalizing all FRUs in the countries. To achieve 100%, yes, in any of the programs we are launching. It could be for mother, it could be for child or elder, for any program, okay, the government is launching. The most important is to implement it to the ground level, and the ground level means the first referral units. Yes, the primary healthcare centers, the sub centers, if they are working, okay, if they are operationalizing, then only we can achieve the benefits of the program. While operationalizing the thirst in on the critical components such as, and what are the critical components, how they will be operationalized? Only when there is a proper infrastructure. Yes, and infrastructure requires lot of things like manpower. We need the skilled workers, skilled health professionals, means doctors should be required. Yes, then nurses, pharmacists, yes, lady health visitors, then ANMs, auxiliary nurse midwiferys. So, they all are the part of the manpower, and if we have them, of course, then only we will provide the infrastructure to the patients. Blood storage facility should be there at FRUs, first referral unit, and referral linkages. Yes, referral linkages means if any person is approaching, and person here is of course the pregnant women, is approaching to the PHC, there should be a linkage from primary to the secondary or to the tertiary. Okay. Now, skill based training programs. So, we will see availability of a trained manpower. This training is provided to the doctors as well as to the nurses, and we have weeks of programs. Yes. So, the initiative being undertaken in this regard are to increase, to augment the skilled health professionals. So, what are these programs? Let us see on the slides here. First is the 18-week training program. Yes, and this program is provided to MBBS doctors. Yes, in life-saving anesthesia skills, which is required in the obstetric care. Then there is another program, we have 16 weeks training program of MBBS doctors. Yes, this is also for the doctors, and it is providing the obstetric management skills, which include C-section, cesarean section, sometimes it is required. So, this type of training is provided to doctors. Then we have another training as well, like as a 10-day training program. Yes, it is provided in basic emergency obstetric care for medical officers. There is a one program for 3-week training program. This is provided to auxiliary nursing midwiferys, then staff nurses, lady health visitors as skilled birth attendants referral. Yes, for institutional delivery. Then we have some skill labs, and these skill labs are known as Daksh training. Okay, so this word is important here, Daksh training. For improving the skills of healthcare provides and enhance their capacity for providing quality reproductive, maternal, newborn, child healthcare and adolescent services. So, these are some of the training facilities, okay, which are going on in the healthcare. Now, referral services at both community and institutional levels. So, see, the Government of India has a trust to establish network for basic patient care transportation. So, there should be a transportation facility, there should be ambulances, yes, through ambulances with the aim to reach the beneficiary. And who is the beneficiary? Of course, mother or child. In rural area for quick service delivery, yes, at the time of antenatal as well as postnatal. Presently, the states have given the flexibility to establish assured referral systems to transport pregnant mothers and sick infants. Okay. Infants here means up to the 1 year of the age, newborns up to 1 year of our age. If they are sick, we have the facility to provide the transportation to sick infants as well. I hope this is clear to all of you. Then meet in the next lecture with the part number 2 about the National Health Program for Mother and Child. Thank you so much.